Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks everyone for having me. I'm going to be kicking off a three-part series of updates from CROI this year. And we'll actually be going a little backwards from the order that they were originally presented in. And I'll start with co-occurring conditions. I have no disclosures, and I'll just present the disclaimer, the usual one. Today, I want to focus, as you can imagine, co-occurring conditions is kind of a grab bag of a lot of different things, many of which are really exciting that our patients face every day. And I tried to focus on things that I thought were really interesting, both from a science perspective, but also that might really impact our care of patients every day. So I'll go through some updates in HIV and TB management, updates in ART and weight gain, and then finally I'll end with an update in Hep B vaccination. So starting off with HIV and TB co-infection. So I wanted to highlight the Dolphin Mom study, and not just because it has a great name, but it is, I think, a really interesting study to think about the impacts of our patients who are pregnant. So this was a study of pharmacokinetics of dolutegravir and HIV viral suppression with 1-HP or 3-HP in pregnancy. And so we know that for women with HIV, active tuberculosis risk is highest during and just after pregnancy and leads to poor maternal and infant outcomes, even in the setting of treatment. And so switching gears to, instead of active TB, thinking about latent TB, for people with HIV who need TB preventative therapy or TPT, we have these new short course options, which I've talked about here and some others have also talked about in this forum. 3-HP, which is 3 months of weekly isoniazid and rifapentine with daily dolutegravir, and 1-HP, which is 1 month of daily isoniazid and rifapentine with twice-a-day dolutegravir. And these have similar efficacy and increased adherence and fewer adverse events compared to our previous standard, the 6 months of daily isoniazid. But, as is often the case, pregnant women were excluded from all of these trials of the short course rifapentine-based therapies. And we already know there's a pharmacokinetic reason for us to be anxious about these therapies because pregnant women have 25 to 30% lower dolutegravir troughs than non-pregnant women. And we already know that the rifamycins impact dolutegravir concentrations and lower them. So we're kind of left with isoniazid, so for pregnant women. So both the WHO and US CDC recommend daily isoniazid for TB preventative therapy in pregnant women with HIV. But we also have RCT data that there's increased adverse pregnancy events with 6 months of isoniazid in pregnant women versus postpartum. And so in some countries like South Africa, there's actually now a recommendation to not use the 6 months and just wait for postpartum. So this is all to say this is not great for pregnant women who need TB preventative therapy. And so the study here looked to investigate what happens to the pharmacokinetics of dolutegravir with these short courses in pregnant women. And I also want to acknowledge that the Dolphin Moms team includes as one of the co-chairs, one of our very own at University of Washington, Dr. Sylvia LaCourse. So Dolphin Moms, the overall goal of this trial is also to look at safety and tolerability of these drugs in pregnant women, but what they presented at CROI was the PK data. So this was a phase 2 randomized controlled trial of either of these short course rifapentine-based therapies and the PK of dolutegravir. It's ongoing in South Africa. And women are enrolled in the study in the second and third trimesters and then randomized to either 1-HP or 3-HP. And as I mentioned, they'll also look at primary safety outcomes, and that's still ongoing. Everyone had to already been on antiretroviral therapy with a dolutegravir-based therapy for a month or more with viral suppression. And the primary PK outcomes were population plasma PK parameters of dolutegravir with or without the 1-HP or 3-HP. Secondary outcomes are viral suppression, and then we'll talk about daily versus twice-a-day dolutegravir in a modeling study. And so what you can see here in the way things were randomized, there's arm 1, which is daily 1-HP plus twice-a-day dolutegravir, and everybody got twice-a-day dolutegravir at study initiation because of that concern about lower dolutegravir troughs in pregnancy. And then arm 2 was the weekly 3-HP plus twice-a-day dolutegravir. Then they got a day 1 dolutegravir level, everybody, prior to getting rifapentine. Then they got a day 17 level. And then those in the weekly 3-HP strategy, they got a day 52 level. What you'll see in the next slide, I just want to note that you'll see two levels for everybody because they got PK sampling done at 11 and 12 hours post each dolutegravir dose. And these were the first 25 participants per arm who were enrolled in the PK sub-study. So this is a busy slide, but again, there's a lot of boxes because each arm had two different dolutegravir levels. I'll just run through and say 50 women were enrolled, 25 in each arm, as I mentioned, mostly Black, non-Hispanic. They had high CD4 counts and they were virally suppressed. And you can see the dolutegravir concentrations on the y-axis and the time on treatment on the x. There's different dolutegravir cutoffs on the dashed lines. And from what I can tell, they just picked a bunch of levels. 158 is kind of a consensus in non-pregnant people with viral suppression as therapeutic, although there's nothing really detailed as this is your therapeutic dolutegravir concentration beyond some studies. And so that was kind of our threshold mark. So what you can see is day one, there were no differences in the dolutegravir concentrations between the arms. But by day 17, there was a significant difference between the 1 HP and 3 HP, both between the arms as compared to day one. So there was lower concentrations for both. But notably, they all remain above that 158 threshold and really above an even higher threshold, that 300 threshold for dolutegravir therapeutic concentrations. I will note that there are those circled dots, and those represent two women who had adherence challenges and thus had very low dolutegravir concentrations. Both of them were able to maintain, or again, viral suppression, or in one woman who became viremic, again suppressed later. And so this is interesting PK modeling part that I'll admit that the math is a little beyond me, but the study took all the data and did simulations now with these levels and said, what if we did daily dolutegravir with 1 HP and 3 HP? And what I want to note is that blue line for 1 HP in the middle is the median levels. And then these are our 5th and 95th percentiles. But basically, anytime we fall into this pink range, we're subtherapeutic with dolutegravir. And same thing over here in 3 HP, the pink is subtherapeutic, the light blue line is median, and then you have your 5th to 95th percentiles. And so I think the big takeaway here is, at least in a modeling study, 1 HP with daily dolutegravir, perhaps unsurprisingly, isn't safe. You see very low dolutegravir concentrations. But in the 3 HP simulation, nobody fell into the subtherapeutic range based on the levels we had. So what are our takeaways? In pregnant women with HIV, twice-a-day dolutegravir with either 1 HP or 3 HP resulted in appropriate dolutegravir troughs and continued viral suppression. In simulation models of daily dolutegravir, with 1 HP, dolutegravir troughs were below the acceptable threshold, suggesting a need for twice-a-day dolutegravir with this regimen in pregnancy, as not in pregnancy. But in 3 HP, all dolutegravir troughs were above the acceptable threshold, suggesting that we might be able to give daily dolutegravir with this regimen in pregnancy. And so what's ongoing is enrollment of an additional 25 women on 3 HP and daily dolutegravir in real life, not in just the model, with subsequent PK sampling. So we'll be waiting for those results. Okay, so now pivoting to a poster. Bear with me, we're still within TB, but different poster. So this I thought was really interesting because I think it really impacts what we do day to day with treatment. So it was called TAF achieves adequate intracellular tenofovir diphosphate concentrations with rifampicin-based TB therapy. And so the reason to do this, so FDA labeling recommends against the co-administration of tenofovir alafenamide or TAF with rifampin. But despite this FDA labeling, there's prior evidence in healthy volunteers without HIV that actually intracellular concentrations of tenofovir were higher with TAF with rifampin than with TDF alone, which is kind of counterintuitive. So the OI guidelines, as opposed to the FDA, actually say, if you all recall, they actually say just monitor for treatment efficacy closely, maybe check a viral load a little more often if you're co-administrating rifampin with TAF. So this was an open label, 3-period sequential pharmacokinetic study in people with viral suppression on rifampin-containing TB therapy. So that's a mouthful, but what does that actually mean? What they did was they took 18 people who all ended up completing the therapy, and they said they were in the maintenance phase of their rifampin-containing TB therapy. They were on TDF plus RIF, then they were switched to TAF plus RIF, then back to TDF only after completion of TB therapy. And what you can see in this box plot is that intracellular tenofovir concentrations were actually 5-fold higher in the TAF plus RIF administration arm when compared to TDF plus RIF, both during treatment and then TDF only after treatment. So I think for me, that was really reassuring. I think many of us have been doing this close monitoring with someone who has a need for TAF, who also needs to be treated for whether TB or LTBI, and really we're thinking about rifamycins as an option, that we really think that our tenofovir intracellular concentrations will be sufficient. Okay, now I'm talking quickly as usual, but I wanted to now really pivot into a new comorbidity or co-occurring condition, which is weight gain. So I know we've talked about this a lot in this ECHO forum. It's a hot topic. Brian Wood has talked a lot about this and written about it. So why talk about it some more? So just to review, some weight gain is expected with antiretroviral initiation. Part of this might be a return to health phenomenon. Some might be direct effective drugs. And there's signals for independent weight gain effects of both INSTIs, so integrase inhibitors, plus TAF, with the greatest weight gain in combination, although also seen alone. And this is true both for people switching from their prior ART to this combo and to those who are ART naive and then starting. What's the mechanism? We don't know. There might be some weight suppressive effects that we've seen of drugs like efavirenz and TDF. There's probably some synergy between TAF and the INSTIs, but most of this data that we've seen has been in cohort studies, right? We've seen that Reprieve has added to our data most recently with increased risk of weight gain with a switch to INSTI. But the question about whether weight gain on ART is reversible, we don't have answered yet. We're waiting for the results from the DO-IT trial, so the switch to doravirine-based therapies. And the only thing we really have is in a sub-study of ADVANCE called CHARACTERIZE. We saw that some women who had switched from TAF to TDF as part of their standard of care, so this is just observational, who were maintained on dolutegravir and lamivudine at the same time did lose about 1.6 kilos, but men didn't. So a lot to still figure out about what's going on. So what did CROI add to our understanding this year? So I want to highlight the switch to Biktarvy or Bic-TAF FTC from dolutegravir 3TC or Dovato in the Paso Doble study, so the series of dances that are naming the two drug studies. So we'd already seen from the AIDS conference last year that in Paso Doble, switching antiretroviral therapy from the two-drug dolutegravir lamivudine versus switching baseline ART to the three-drug Bic-TAF FTC in people with HIV who are virally suppressed was associated with less weight gain. So you're on something, you're switching to the two drugs versus three drugs, and you gain a little bit less weight. So two of the posters, and there were a few more actually, but these two I thought broke out some nice takeaways for this weight gain. So in the first, in the switch of looking at subgroup analysis of efficacy, and I bolded what I was interested in this case, which was the clinically meaningful weight changes, so more than 5% from baseline. We saw significant lower proportions of people with HIV with significant weight gain in the two-drug therapy arm in women, those who were 35 to 50 years, and those of Latin American ethnicity, those with a high pre-switch CD4 count, and those who were on TDF, FTC, and NNRTI containing therapies. And so this is as compared to the three-drug BF-TAF arm. In the second poster, what about body composition changes? I'll say the takeaway when we look at whole body DEXA and abdominal CT is that there were significant increases across the board in fat compartments and decreases in lean mass compartments, but those changes were greater, so more increase and more decrease in lean mass in the three-drug Bic-TAF FTC versus dolutegravir 3TC. And then finally, tenofovir and efavirenz, TDF, I should say, and efavirenz at baseline were associated with significant difference in visceral and total fat mass changes. Those were switches from prior ART to either two or three drug therapies, one containing TAF, one not, but both with INSTIs. What about the impact of switching from dolutegravir lamivudine to three drug therapy, so adding TAF effectively to our integrase? So the INSTINCT trial was looking at that switch precisely. They were really looking at systemic inflammation, but I thought it was really important that they also looked at weight changes. There was no difference in weight changes between groups. So I think another meaningful addition to our body of knowledge. And then, as if I wasn't going quickly enough, here's a weight gain rapid fire, just other posters I thought were interesting. What happens if you discontinue abacavir and are left with dolutegravir lamivudine if you were on the three drug therapy first? Didn't change a thing, so no change with dropping abacavir. Next, what about body composition changes in switching from or maintaining TDF-based regimens? So this was an observational study over 10 years looking at lean and fat mass in a majority male and middle-aged population, either maintaining TDF or switching. And switching to TAF was associated with an increase in BMI and stabilization of lean and fat mass. And then finally, what about extreme weight gain? So people who gained more than 10% instead of 5%, which we were considering clinically significant in many of these studies. The association was within 5 years, and this cohort was with younger age, a higher baseline CD4 to CD8 ratio, a switch to TAF, and there was a trend towards extreme weight gain in those who switched off of TDF. So what are our takeaways here? HIV and ART-related weight gain remains multifactorial and complex, but there's more evidence that initiation of TAF plus an INSTI, the second generation one I should mention explicitly, is associated with more weight gain than the integrase alone, suggesting some sort of, again, synergistic or additive effect. But switching from the INSTI to a combination of a TAF plus INSTI doesn't appear to drive further weight gain, at least in one study. And TDF continues to be associated with attenuation of some metabolic and mass effects. And then someone will ask the question, so I'm just going to ask it up front, what do we do? We still don't quite know. So we know that there's studies looking at the use of GLP-1s. Last year, I talked about slim liver. There was more data presented this year about not just hepatic steatosis with the addition of GLP-1s, but thinking about strength, functionality, and other aspects that we shouldn't be missing when we think about, instead of thinking about just weight alone. Okay, and finally, I'm going to take one last pivot into the world of hepatitis B vaccination in people with HIV. You've now probably heard at least 3 different presentations about Beehive, but just as a reminder, this is HBV vaccination in persons living with HIV. I want to recap the study design and the rationale, but Hep B vaccine seroprotection rates in people with HIV are lower than in adults without HIV with a conventional Hep B vaccine with an aluminum adjuvant or Hep B alum. And so the study, remember, had arms A and B. Arm A was Hep B vaccine prior non-responders, and they were randomized to either Hep B CpG or Heplisav B is the brand name, 2 doses, 3 doses, or the conventional aluminum adjuvant, 3 doses. And then within arm B, the vaccine naive, they were all given Hep B CpG 3 doses. And so just as a reminder of what happened in prior results that have been presented, Arm A, the vaccine non-responders, people with HIV who didn't respond to the conventional vaccine achieved superior seroprotection as compared to 3 doses of conventional vaccine. 3 doses of Hep B CpG achieved a high proportion of seroprotection with Hep B surface antibody titers greater than 1,000. So 78% achieved that in the 3-dose arm. In the vaccine naive arm, all people with HIV who received the 3-dose Hep B CpG or Heplisav B vaccine achieved seroprotective response. And just as a reminder that you only need greater than 10 for that definition. And again, 84% achieved greater than 1,000. And then 98.5% achieved seroprotective response after just 2 doses, though at lower titers. So here only about a third got to the 1,000 threshold. And so at CROI this year, the authors presented the 72-week durability data for both arms. So this is the group A 72-week results. And so the vaccine administration days are those triangles for each arm. And I just want to highlight the end of study anti-Hep B surface antibody titers that are still seroprotective. So in the 3-dose arm, that's 97.2%, and the 2-dose arm, that's 86%. And it's a pretty dismal in comparison, 57.5% in the 3-alum arm. And then what about people who achieved seroprotective response at any time on the study, but then lost it by study end? That was only 2% in the 3-CpG arm, 10.7% for the 2-CpG arm, and then a 22% in the 3-alum arm in the conventional vaccination strategy. What about group B? Again, the reminder, this is vaccine naive. The graph just has it overlaid on the 3-CpG arm and group A. You can see they're pretty similar. Initially, a little bit of difference based on prior vaccination, but then they get superimposed. So again, our end of study anti-Hep B surface antibody titer greater than 10 was 97.3 in the 3-dose CpG arm, which is about the same as in the prior vaccination 3-CpG arms. And then what about durability? Primary seroprotective response was 100%. And end of study was 97.3%, so pretty minimal loss. And this is, again, a busy slide, but I like it because it kind of shades and looks at how many people got to this greater than 1,000, then 100 to 1,000, then 10 to 99 seroprotective response. And then the grays are people who didn't achieve a seroprotective response in each arm. And what I really want to highlight is the takeaway, though, is that higher primary surface antibody titers were more likely to lead to seroprotective response by the end of study. So end of study seroprotective response was 100% of those with titers greater than 1,000 at primary response. It was conversely 0% in those with titers less than 100 in the conventional vaccine, the allomadjuvant, at primary response. 2/3 with titers less than 100 in the 2 CpG arm at primary response. And there were not enough people with titers less than 100 at primary response in the 3 CpG arms to say, which I take to mean so many people got super high titers in those 3 CpG arms. So our takeaways here: in people with HIV, higher end of study seroprotection was achieved with Hep B CpG or Heplisav-B over Hep B alum, and among CpG 3 doses over 2 doses. Hep B CpG led to durable seroprotection in both vaccine naive and prior vaccine non-responders for hepatitis B. This begs the question, do we really need 3 doses after such a good response after 2, especially in vaccine naive? Maybe not, but I think it helps us think about how we might counsel our patients. I added this nota bene that low CD4 counts in HIV viremia were not well represented in the study. And so now that we see that to some extent higher antibody response equals longer durability, it may make us think that for our patients who have less of an immune response in general, they may benefit from all 3 doses. And so just to close us all out as a reminder, since we covered so much territory here, in pregnant women with HIV, twice-a-day dolutegravir with either short course rifapentine therapy with 1 HP or 3 HP was favorable from a pharmacokinetic perspective, and daily dosing of dolutegravir with 3 HP might be. There's increasing data that ART-related weight gain is complex, and we need more data regarding the impact of a regimen switch. And Hep B CpG or Heplisav-B is superior to conventional Hep B vaccination in people with HIV and is highly durable.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.